The actual system, the way it's set up, which is part of what this report focuses on, are there perverse incentives? Because as it stands, what it suggests is, and GPs have spoken about this before on the program, that the incentive is churn through appointments. If you're going to go sub 15 minutes, the shorter the better, and those longer appointments, which some people really need for chronic conditions, are actually some of the worst sort of dollar results, if you like, and GPs still run a business as well for a GP practice. What's your reaction to that?
Yeah, so it's really important that, and this is actually needed as a matter of urgency, is that those longer consultations around chronic disease, around mental health, around the types of things that our patient needs are adequately remunerated through the MBS. At the moment, the longer you see someone for and provide care for, you're penalised. So we're calling on the government to increase the rebate for patients for those longer consultations, and to also triple the bulk billing incentive for our vulnerable patients so we can provide that care.
Right, so that would seemingly fix the perverse incentive I spoke about. What about the other suggestion for other clinicians to be based at clinics? A lot of people would say you go to a GP and then you have to go to someone else, and each time you're taking time out of work, it's ineffective for them and for workers as well. What's your reaction to that?
So we support having our allied health colleagues and other health professionals working in the practice with the GP, and that is the ideal model. The models where we start fragmenting care, which is what's happening with the pharmacy pilot at the moment, is actually creating an even bigger disincentive. And siloing and fragmenting of care actually has poor outcomes. So we do support GP-led multidisciplinary care.
Right. What's the fragmenting issue there that you're talking about?
So at the moment, what's happening is that people are getting their primary care in different places, and there's now a pharmacy trial that's happening in various different states where different people can access care not from their GP but from their pharmacist. Now, what we would prefer is that everybody works together in a team-based approach. And what's happening with the government is, at the moment, funding these systems, we've got a workforce shortage across the whole primary care sector. It's not just GPs, it's nurses, we're 8,000 short, it's pharmacists, it's paramedics. So borrowing from one profession to fill a hole in another, that's not the solution.
A lot of people that have dealt with needing to see a GP to get something like a prescription or whatever it might be, particularly when a GP's booked out or maybe a holiday period, would welcome pharmacists having a bit more of a say in that, for example. So a condition, you just have to get to a GP, there's no way to get a prescription for it, and you end up going to a hospital instead, say on Christmas Day. Is there a place to, at least when demands like that or when GPs are shut, to have this sort of option? Because it seems common sense from where I'm sitting from.
Yeah, I think there's also other things that we can be looking at through that, such as increasing the length of dispensing so that patients don't need to go to their pharmacist every month to pick up a script. They can get it every 3 months. There's lots of other solutions with how we can manage and help our patients navigate the health system.
All right, we'll leave it there. That's another issue I'm sure we'll touch again, Dr. Nicole Higgins. Thank you.
Thank you. Cheers.